Good morning, everyone. We will start the meeting shortly. Those who have not registered, we will request you to kindly scan the QR code and register for the VC. Thank you.
Hmm. हाँ सर सर क्या ये आपका नहीं नहीं
Very good morning, all. Kindly scan this QR code to fill the pretest questionnaire if you have not already filled. We'll shortly starting the meeting sharp at 10.
एक पार्टिसिपेंट 2 गेम में पार्ट ले सकता है क्या? लिख दो यस। ये कौन है? यस लिख देते हैं। आप लिख
सामने से
मैम आपकी अमृता है, आपकी म्यूजिक
we are shortly starting the meeting in 2 minutes. Those who have not registered yourself. Good morning, sir.
Good morning, sir.
Dr. Vijit, very good morning. Am I visible and audible?
Yes,
Yes,
sir.
sir. Yes, sir.
Okay. So, very good morning to all.
Good morning. मुझे लगा
A very good morning, all. Welcome to the fifth regional virtual workshop on tobacco use among tribal and indigenous communities of India. So this time we are summing up the whole proceeding. We have total 5 virtual workshop under our project, led by Professor Dr. Saurabh Ajnesar, our Executive Director and CEO. So he is currently at airport traveling to Deoghar. So I would request AD sir to give his opening remark.
Thank you, Dr. Bijit. Am I audible, Bijit?
Yes, sir, you're audible, sir.
Okay. So first of all, thanks to Dr. Bijit and team of Better Strategies, AIIMS Deoghar. I think the team has been working very hard on tobacco control in tribal health, the tribal community, indigenous community. In the same series, we, as mentioned by Dr. Bijit, we had planned 5 virtual workshops on various aspects of tobacco consumption in tribal health. And today it's a final wrap-up virtual workshop that what we learned, we understood in the last 4 workshops. We are going to consolidate it. Professor Janvi is the lead as a chairperson of this workshop, supported by Dr. Santanu, Dr. Sudeep, Dr. Vijay, Dr. Arshad, Dr. Vinayak Murthy, and if I'm missing out any name from our team, then we have a support team, Dr. Benazir, Dr. Ujjwal, and Nivedita ji, and Dr. Narsimha in particular, because he has been a support from the very beginning. So this team has really worked hard. I'm really thankful and grateful to all the guest faculty who have been supporting us in this endeavor from the very beginning. And today also they have agreed to join. In particular, Professor Sonu Goel, Dr. Atri Gangoli, Dr. Bhujani, Mr. Deepak Mishra, and Dr. Pankaj had joined us in one of the virtual workshops. So we are really thankful and grateful to our guest faculty for being giving time, giving their expertise and their comments during this. I'm very happy to also announce that in May 2024, we are going to hold a national conference on tobacco and tribal community and indigenous community. Dates will be communicated very soon. We'll be expecting all of you to be a part of that great event. And since I'm traveling, I'm sorry that this is the only virtual workshop I'm not able to attend in person. But my best wishes are always there. So I hand over to Dr. Bijit to kindly start the proceedings without delay. Thank you very much. Thank you.
Thank you, sir, for your words of wisdom. So without delaying further, we are starting the proceeding of the workshop. So first, I would like to welcome our internal speaker and co-lead in this project, Professor Dr. G. Janvi ma'am. Professor Dr. G. Janvi ma'am is professor and head in the Department of Community and Family Medicine at AIIMS Deoghar. She is a proud recipient of 27 Dr. S. Radhakrishnan Memorial National Teacher Award at 2011. She is faculty. He has also won a faculty best paper award and chaired various sessions at national and international conferences. Have more than 35 publications in various national and international journals. So we are glad to have you with us, ma'am. So kindly start the presentation. Ma'am will deliver on first. Ma'am will introduce our project. Then we'll deliver the internal talk, which is planned for this session. Ma'am.
Respected ED sir, my co-PI, and all the panelists, the delegates joining online.
I will request all the participants who have joined kindly mute their mics because it's hindering the proceeding of the workshop. Please mute yourself. Okay, ma'am, please.
So today this is our wrap-up session of this is our 5th virtual conference on the topic strengthening commitment to tobacco control through stronger participation of medical institutions to counter tobacco industry interference. This project is funded by Vital Strategies. So this is our team lead is Professor Dr. Saurabh Varshney sir, our Executive Director and CEO. Under his guidance, we are doing this work. Our other co-PIs are Dr. Narsimha, Dr. Shantanu, Dr. Vinayagamurthy, Dr. Sudeep, Dr. Arshad and Dr. Bijit. And our project staff, Dr. Benzit, Dr. Ujjwal and Ms. Nivedita. So our study objectives are to sensitize and develop strong commitment from medical associations and institutions, including leading hospitals at national and subnational level to advance tobacco control, establish a center of excellence to advance tobacco control among tribal and indigenous communities of India, support the states of Jharkhand and Bihar with compliance surveys, support Deoghar Temple Town to achieve tobacco-free status by 2024 based on compliance studies and high-level declaration. So this is the burden. According to GAS 2016-17, Jharkhand is having the highest current tobacco users and also the highest prevalence of tobacco in compared to the all India average. So these are the sensitization conferences and workshops which we have done.
सर्जन जो होता है बड़ा कूल माइंड होता है, पता नहीं ये कौन सा सर्जन है.
All the participants kindly mute yourself.
ब्रेन का सर्जन है.
Participants kindly mute yourself. You are hindering the proceeding of the workshops. I request all the participants kindly mute yourself.
So these are the various conferences where we had sensitized the people along with our 4 virtual conferences. So the various conferences which myself and my co-PIs and our PI have attended were Rishikesh, Goa, Deoghar, Mumbai, Jaipur, and our coming conference which we will be attending is in Jharkhand, Ranchi. So these are World No Tobacco Day celebrations which we have supported through our Vital Strategies. We have funded the other medical and dental institutions of Bihar and Jharkhand, which you can see here. So many colleges have observed this event in their own colleges in their way, which was funded by the Vital Strategies. So these are the list of medical and dental colleges which have declared conflict of interest statement on their website. And these are the national consultations and workshops in tobacco control where our co-PIs have attended. And AIIMS Deoghar has been declared a Center of Excellence for Tribal Health. The Ministry of Tribal Affairs, Shri Arjun Mundaji, has attended this and he has declared it during our tribal summit. This is our AIIMS Deoghar Union Tobacco Control website, which was launched on 22nd, 22/9/23. And anyone interested can go through this website to see the activities which we have been doing. These are the messages for our website from various ministers of these are the letters of appreciation. So now coming to leveraging medical colleges for tobacco control among tribes. So this I will be talking about the burden of tobacco use among tribals, FCTC, COTPA, and role of medical colleges for tobacco control. Coming to FCTC. Now, before going to FCTC, I would like to say that prevalence of tobacco use among tribals is high, based on the meta-analysis which this is just a preliminary analysis which we'll be doing further. So state-wise prevalence of different forms of tobacco among tribes. In this also we can see that Jharkhand plays a high role. Bihar and Jharkhand has the highest prevalence of tobacco use. So here, a study by Agarwal R weighted prevalence of different types of smokeless tobacco use. Even in this, Jharkhand and Bihar has very high prevalence. So the impact of tobacco use among tribals is because of the health consequences. They pose a significant public health risk in the tribal communities. And the economic burden also is there because of this. And there is a cultural erosion because we are disrupting the traditional practices of deep-rooted tobacco use in their deep-rooted historical roots. Coming to tobacco industry interference, tobacco is the only legally available consumer product which kills people when used entirely as intended. There are 275 million tobacco users in India, and tobacco industry globally hampers public health policies in tobacco control strategies. So these are the tactics of them. They say that they are supporting, but really they're not. And out of the blue, there is some new lobby which says something or the other about tobacco use. And right now, like Philip Morris, it is a big tobacco industry, but they say that they're supporting, but actually they're not supporting. They are advertising their company. And there is an invisible editing hand, and they say that they're supporting youth prevention programs, but actually they do not. And we all know that there is so much money with this tobacco industry, and they change all the things. So we need to be careful. So the tobacco industry interference overall country ranking, our country ranks around 58. So this is the comparison of 80 countries. Actually, we were below this, but because recently the Indian Institute of Technology has signed an MOU with ITC, our ranking has gone down. So these are the guidelines. The 4 key principles are: there is a fundamental and irreconcilable conflict between the tobacco industry's interest and public health policy interest. Principle 2 is parties when dealing with the tobacco industry or those working to further its interest should be accountable and transparent. Principle 3 is parties should require the tobacco industry and those working to further its interest to operate and act in a manner that is accountable and transparent. And the last principle is the products are legal, the tobacco industry should not be granted incentives to establish or run their business. So how to implement is we have to raise the awareness, we have to limit the interaction with the tobacco industry, we have to reject the partnerships with them, we have to avoidance of conflicts of interest, require disclosure of information, denormalize the tobacco industry's corporate social responsibility activities, and do not give any benefits or tax exemptions. Now coming to COTPA, there are various sections under COTPA. Section 4 deals with prohibition of smoking in public places. 5 deals with prohibition on advertisement. 6 say prohibition of sale of tobacco products to and by minors. 6B prohibition of tobacco sale within 100 yards of educational institutions. Section C deals with specified health warning labels on all tobacco products. 12 power of entry and search, and 13 power to seize. So these are the various penalties under the sections. So this is how complying with law as per GATS to 28 states and union territories have implemented CODPA, and this is how they have to display their signages. These are the how they have to display. These are the 4 regional workshops which we have conducted till now, and this is the 5th. And out of this 4 regional workshops, what we have, the key points evolved were: tobacco use in tribal population is deeply rooted in their cultural practices, often guided by traditional leaders. The adoption of CODPA and TOFI guidelines is in tribal areas has to be done. And myths and health benefits surrounding tobacco use has to be addressed into, and community mobilization, community participation, and inclusion of tobacco control in Gram Sabha discussion agenda should be the innovative strategies to address these issues. So this is a sensitization workshops where we have just analyzed the data, and we can see that after the workshops, the knowledge and the awareness and about FCTC and CODPA, everything has become more before and pre and post. If we see, it has become more, and the p value also is significant. Now coming to the focus group discussion which we have done in Jharkhand and in Deoghar. These are the villages which we had gone to, and we did focus group discussion. And there we can see that among them almost everybody is illiterate. And the burden is how the gender is influencing tobacco use. We had seen in a focus group discussion that 8 out of every 10 males were using tobacco and females were not using. But when we probed into it, we could see that they were stealing from their husbands and using it. And elderly females also were using tobacco and alcohol. So this is the word cloud of transcripts. And we had attended, myself and Dr. Shantanu have attended a meeting of District Tobacco Control Coordination Committee meeting, and we had put up our issues over there, and later on followed by 2 meetings of advocacy meetings where all of us have attended. And in this, some takeaway messages were, we had asked the administrative officers, we made them aware about CODPA Act provisions, and they even the Panda Samiti committee has attended the meeting where they said that most of the pilgrims don't use tobacco, but those people who live in and around the temple are violating the law. And the IMA people who have attended had promised us that in their clinics they would put a tobacco-free display signages, and also in their prescription patch they would write that tobacco is not, it is bad for health. And TOFE guidelines also, they said that they would follow. This is a newspaper press release of meeting.
Okay, तुम्हारा कौन सा वाला है?
This is a map showing participating institutions of tobacco burden and perception survey. In this, I would just like to highlight that this study was done among the healthcare professionals of students, faculties, and staff of Bihar and Jharkhand. So the overall prevalence was 28.6%. In Bihar, it is 25.9%, and Jharkhand, 38.9%. So this is the distribution of study participants as per the knowledge about smoking not allowed in public places. This is a perceived effective tobacco control measures. According to them, the penalty, if we give penalty, that is the most effective control measure, and the least effective is warning displayed on the tobacco products. So most of the students, dental students, nursing students, and medical students said that we should be giving more emphasis in the healthcare curriculum as per them. We need to introduce the health about CODPA guidelines into the curriculum. And tobacco control should be given more emphasis according to dental faculty, nursing faculty, and medical faculty also. So to conclude, our research reveals disparities in healthcare tobacco use influenced by various factors like age, gender, marital status, occupation, income, and native state. Non-tobacco users had higher knowledge related to CODPA in comparison to tobacco users. Notably, tribals had comparable knowledge regarding legislations with higher age of initiation, there is urgent need to integrate tobacco education into the curriculum to sustain awareness campaigns for effective dissolution. So these are the role of medical institutions where we can chip in into clinical services, tobacco-free campuses, building partnerships to support research, education and training, IEC and community participation, NTCP monitoring and evaluation, and advocacy. So these are some of the take-home messages. Create awareness among students, patients, communities regarding ill effects of tobacco and related legislations, display of signages in the campuses, upload conflict of interest of statement on your respective websites, elicit and document history of tobacco use among all the patients, whoever is attending the OPD or in our subject, like whoever is going into the field and seeing the cases, and linking of tobacco dependent patients to de-addiction facilities. This is the quit helpline number 1800112356. Thank you so much. Zindagi chuno, tambaku nahi.
Thank you, madam, for such a lucid talk on the various activities what we have done under the project and why tobacco control among tribal and indigenous communities is vital, because they have the twice prevalence in compared to the national average as per CATS2. So to tell it about it bit more, we would now like to invite our external speaker, Dr. Upendra Bhojani sir. So Dr. Upendra Bhojani sir is a dentist transitioned into the public health 15 years ago. He has been working in the Institute of Public Health, Bangalore, and served as a director since last 15 years. He is a faculty member and DBT Wellcome Trust India Alliance Fellow. He leads the cluster of chronic health conditions and public policy, and he has been engaged in research and knowledge that translations into tobacco control for over a decade and a half. He is co-PI in Indian Alliance funded multi-institutional center on training, research, and innovation in tribal health. Welcome, sir. Sir, I would like to invite you to deliver your talk, sir.
Thank you, Dr. Bijit. Am I audible?
Yes, sir, you're audible, sir.
Okay, great. I won't be using slides, so I'll just share my observations. First of all, I'll start by, blessing my, appreciation to AIIMS Deoghar, you and your team, the director, for really spotlighting this neglected issue of Adivasi communities and tobacco. And I have had the privilege to be part of most of the earlier workshops in the series. And with this one, the fifth one, we are kind of winding up the series. So what I'll do in next 15 to 20 minutes that has been allocated to me is to really provide some of the key takeaway points, because several internal and external speakers have shared on various aspects interlinking tobacco and Adivasi communities. And it would be not possible really to summarize everything, but what I would rather like to do is to thematize some of the major sort of takeaways, at least for me, and I hope it is useful for others. So let me start. I have planned, my inputs into three separate thematic area. Let me start with the first, which is tobacco use among Adivasi communities. And I think to some extent, previous speaker highlighted that if you look at available studies in India, there seems to be, I mean, as a big picture, there seems to be a very high prevalence of tobacco use among Adivasi communities. If we look at big data sets like, let's say, NSSO, the National Sample Survey Organization, which has been conducting periodic surveys over a long period of time. And then I analyzed for the last 30 years, and what we see is that when you differentiate, you segregate tobacco use by social groups, then you see that, 99, the scheduled tribes as a category had the highest prevalence of tobacco use, followed by scheduled caste, other backward caste, and general or other categories. And then over last 30 years, while there has been a general decline in tobacco use at national level in India, what we also observe is that not only the tobacco use remains still highest among scheduled tribe category, but the decline in tobacco use prevalence has also been the least over last 30 years, meaning the gaps across social groups have actually widened over last 3 decades in India. I think we also need to keep in mind that scheduled tribe is kind of an amorphous category. It puts together very kind of community with very diverse ethnicity, with very different life contexts, the kind of environments in which they live. And so it might also be actually important to then focus on specific communities, as we know that the what we call Adivasi communities are not a very homogeneous group of people. And in that sense, also we have now increasing number of smaller studies which are more localized and telling us what is the tobacco use, among different forest-dwelling Adivasi communities. And unfortunately, most of those studies also point out the similar finding that the tobacco use remains high. However, what we probably don't know much about are the more definitive reasons for such a high prevalence, because in general, people may argue that tobacco use is often an engineered addiction, and the tobacco industry sort of promotes it through aggressive marketing, etc., etc. But at least among many of the forest-dwelling Adivasi communities, this may not be the primary driver. And so I think the thing is that we can't separate out tobacco use from its various socio-cultural and historical pathways. And I think we need to know more about this, because despite tobacco having a relatively short history in India, it comes to India only by the turn of 16th century. And initially, it was largely prevalent among more wealthy and elites who were connected in power circles. What leads to the current situation? So the tobacco somehow got integrated into customs and rituals of several Adivasi groups in India. And also what I observe is that it's not always without contradictions. For example, some of the Adivasi community groups that I am familiar with in Karnataka, the state where I reside, some years ago, at least a couple of decades ago, tobacco was not considered acceptable. There was a taboo, there was a kind of norms which prevented community folks to use this substance. But today, that's not necessarily so. So I think there is also a bit of a contradiction between the kind of prevailing norms and also the practice. Also, I think now many of us acknowledge that for various reasons, many of the Adivasi community members have to now migrate for wage labor, and again that kind of exposes them from a very protected ecosystem that they have very well adjusted to a very different world, where again tobacco kind of dominates, and what I said about industry marketing and things is very common. There is also a narrative, of course, about the indentured labor and the plantation labor and the use of tobacco in past. We also do not know much about many of the products which are more prevalent among Adivasi communities. Many of these products remain non-packaged products, non-standardized. Many of them are very local, regional products. And I think we are yet to really understand well the profile of these products in terms of how addictive they are, how toxic they are, what are those chemical and content properties of these products which makes them so widely prevalent in this community. Also, we don't know much about the various plants or the healing practices used by the community members or the healers to treat addictions, because yesterday I met Dr. Nasimha, and he was sharing about how some of the local medicinal plants are used for alcohol, treating alcohol addiction. We probably don't know so much about tobacco, or at least it's not still very wide and popular knowledge. Let me move to the next. So while I try to summarize some of the key takeaways, I think of course they have implications on what needs to be done. future. So clearly, we need to invest more in understanding many of the issues sort of I highlight. Let me move to the next theme, which is tobacco industry and Adivasi communities. Again, I think the previous speaker talked about tobacco industry interference, and I feel that this is again a very complex intersection between Adivasi communities and tobacco industry. I had again privilege to be part of one of the panel discussion in the earlier workshops in this series. So I think there are few things I will highlight which kind of marks the linkages between the Adivasi community and tobacco industry. One is, of course, there is a degree of dependence of some of the Adivasi communities on tobacco industry. They are part of industry supply chains, especially in the sense that many Adivasi communities are engaged in collecting the leaves of variety of plants, of course, more commonly called tendu, but there are many more. Um, uh, One of my PhD student works in Gujarat, and we just had a debrief yesterday, and she was sharing how in Gujarat, in many of the communities that see studies who are BD rollers, they don't use the tendu leaf per se. They use what is locally called asitra, and I think there are not just two but more species of plants that leaves are used for rolling BDs. And this is not just about leaf plucking from the forest, because these leaves and these plants are some of the major sort of non-timber forest products. But many community members are also engaged in the process of BD rolling. And what we know from very few studies available is that those Adivasi folks who are engaged in this are often also more exploited and live in much more marginalized situations compared to other non-Adivasi groups who are engaged in tendu plucking or BD rolling in our country. The other, and I think much more fundamental problem for Adivasi communities from tobacco industry is the deforestation. I think we all know that, the centrality of Adivasi identity and the coexistence with nature and with the forest. Forest is really central to their lives. Now, tobacco industry leads to deforestation in two major ways we know, but of course there are many more ways in which it impacts environment in general. One is now we have some documentation, again, thanks to the union for various grants they supported in past, that we have some documentation in terms of how tendu-related forest fires are common and increasing in the whole central India, the various forested tracts where tendu is grown and plucked, mainly because in order to get more yield, tendu plants are often burnt, and often this results into the large-scale forest fires, and of course deforestation. But also we know now, and there is quite enough documentation in terms of how curing,
5588
which is an important process in drying the tobacco leaf to make it ready for further processing of refined tobacco products. You need wood, and this wood, ought to come not from forest sources, but unfortunately, the study shows that a significant portion of wood which is used for curing tobacco often comes from protected forest. And the last part is really not to ignore that the tobacco industry's reach is also expanding. So while even if you go into the interiors, some of the forest dwelling areas wherever the tribal communities stay, we still see that the small vendors are selling some of the more sort of packaged and standardized products. So products availability is going up, but also in many other ways. In a sense, for example, the corporate social responsibility. I saw that in many of the states with significant number of Adivasi inhabitants, there is also increasing focus of tobacco industry CSR on some of the issues that Adivasi communities face. And as you know, the CSR by tobacco industry is, of course, a bit problematic. So now let's move to the third and the last theme that I thought I'll share with you, which is then doing research and doing tobacco control interventions to address this high prevalence of tobacco use and associated burden among Adivasi communities. I think this is extremely important to be done, and that's where I really feel that AIIMS Deoghar has rightly put a spotlight on this issue. But I think in previous panels, including my interventions earlier, has focused on highlighting that how we need to do this with utmost regard to the ethics. I think the earlier speakers also talked about a need for participatory approaches. I think we just can't go there, do some survey and make publications and come out. Yeah, that would be a worse form of exploitative work. I think we really need to learn more and co-develop approaches. It has to be participatory approaches that ensure both the cultural safety, because I think Adivasi identity, as has been highlighted by earlier speaker, is very central, but also possibly promote restorative justice. We do know, the kind of injustice that has happened to our Adivasi folks over a long time. And I think that's why it's very crucial that we are mindful of whenever we try to either do research inquiries or design interventions. We also have to keep in mind that there is already a very difficult access to healthcare services by most of the Adivasi communities, and especially those who stay in forested areas. And this also, of course, mean that we are actually offering very little in terms of cessation support, but also other priority health issues that affects this community. And also there is a poor reach, of course, and I would say not just poor reach, but maybe also some sort of poor alignment of prevailing tobacco control regulations with respect to Adivasi communities. So I think these are the various areas I especially feel are kind of takeaways for me. And thanks to this series of workshops again by AIIMS Deoghar. And thank you for giving me this opportunity to make this intervention. And I look forward to further panel discussion as part of this workshop. Thank you, and back to you, Dr. Bijit.
Thank you, sir. Thank you for summarizing all the proceedings that we have discussed through our various species. So to throw some more light on it, we have a galaxy of stars among with us. So to talk, the stage is correctly set to present our panel discussion, which is on reflecting on our progress and the path forward. So to moderate the session, I would like to invite Dr. Venkatalakshmi Narasimha, sir. Okay, so sir is about to join us. Sir is actually currently, meanwhile he is joining. So we would like to introduce our panelists. So our panelist, we would first like to welcome Professor Dr. Sonu Goyal, sir. Professor Dr. Sonu Goyal, sir. Sir, you have joined, sir?
Yes, he's joined.
Oh.
Sir is
Sir, actually, our moderator for the session, Dr. Venkatalakshmi Narasimha, sir, is joining in a while. He's got stuck in some certain activity. So, so I would like to invite Professor Dr. Sonu Goyal, sir. So, sir is currently Professor of Health Management in Department of Community Medicine and School of Public Health in the Postgraduate Institute of Medical Education and Research, PGMR, Chandigarh. Sir is Adjunct Associate Clinical Professor in the School of Medicine and Faculty of Education and Health Sciences and University of Limestock, Ireland. And Sir is Honorary Professor in the Faculty of Human and Health Sciences at Swansea University, UK. Sir's key interests are leadership and management, health system strengthening, tobacco control, and operational research. Welcome, sir. Good morning.
Thank you very much, Dr. Bijit and the team.
So I would now like to invite our next panelist, Dr. Archie Ganguly, ma'am. Ma'am is currently working as a National Professional Officer in WHO India. Ma'am is a public health professional having experience in implementation of various national health programs. She has been working with WHO since 2010 and focal point with the mental health and substance abuse, healthy aging, palliative care. These are some of the key areas ma'am is currently working at. She was instrumental in carrying out a year-long campaign on depression, let's talk, as a part of the World Health Day in 2017. Ma'am is also member of WHO core team to support national response to COVID-19 pandemic in previous input for towards implementing the mental health pillar of COVID-19 response. Ma'am, welcome, ma'am. We are privileged to have you with us. Ma'am, are you there, ma'am? Ma'am?
I'm there. I'm just trying to. Yes.
Okay, ma'am. Thank you, ma'am. We're privileged to have you, ma'am. So next, I would like to invite our next panelist, Deepak Mishra, sir. Sir is currently Executive Director of Socio-Economic and Educational Development Society, SEEDS. Sir is a trained on tobacco control expert for over 25 years. He is master trainer of mid-level tobacco control managers, of government officials. He's been having good rapport with the regional and state vernacular media. She's instrumental in banning the manufacture, trade, storage, and sale of chewing tobacco products like gutka, pan masala, and she is being instrumental in implementation of WHO FCTC 5.3. He's also a member of task force constituted for Nasha Mukti Abhiyan by Ministry of Health and Family Welfare, Government of India, under chairmanship of the Secretary, Ministry of Health and Family Welfare. And Sir is also member of state level tobacco control coordination committee in the state of Jharkhand and Bihar. Sir, we are glad to have you with us. Sir, have you joined, sir?
Yes, thank you. Thank you, Dr. Vijit.
Thank you, sir. So next, I would like to invite our next panelist, Dr. Amit Yadav, sir. Sir is currently working as a senior technical advisor at Southeast Asia Office Vital Strategies. He worked as a postdoctoral scholar at the Center of Tobacco Control Research Education. He worked in RIDA, PHFI, WHO, IHMR, NICPR, WHO FCTC Global Knowledge Hub on smokeless tobacco. He was also elected member of Board of Directors of Framework Convention Alliance representing CRO for 2016 and 19. He's worked in the field of public health law, policy, research, and published several peer-reviewed papers, book chapters, and reports. He has also authored a book on public health tobacco and trade in India. Sir, we are glad to have you with us. Sir, have you joined, sir? Dr. Amit Yadav, sir?
Just clicking it.
Yeah.
Okay, welcome, sir. So last but not the least, I would like to invite my colleague, Dr. Sudeep Bhattacharya, sir. So sir is currently working as an assistant professor in the Department of Community and Family Medicine at AIIMS Deoghar. Sir is a ex-faculty of AIIMS Madurai, Tondo Medical College, Manila, Philippines, Mary Johnson Hospital, Manila, Philippines, and Asia Metropolitan University, Malaysia. Sir is member of IPHA, IPSM, EFI, AFPI, India. She has more than 100 PubMed publications, total more than 200 publications, including Lancet Regional Health, EMJ Plus. He is editorial board member of EMC Primary Care, Clinical Nutrition, ESPN journals. He has written and edited 3 books, 3 chapters, and 1 booklet, worked in projects worth ₹6 crore, including the Food Foundation and Bloomberg Philanthropies. Sir is also holding the fellowship of Royal Society for Public Health, London. Welcome, sir. Thank you. So I think our moderator have joined. Narsima, sir?
Yeah.
Have you joined, sir? So
Yes.
So I would like to introduce our moderator for the session, Dr. Venkatalaxmi Narasimha, sir. He is currently working as an assistant professor at Center of Addiction Medicine at NIMHANS, Bengaluru. He's have more than 50 publications in various indexed journals. He has a H index of more than 30 and more than 600 citations. He is awarding research. He led research more than 3 research projects and OPI 6 projects. Total funding of 1.6 crores. He is a proud recipient of Best Researcher Award at 2023 at AIIMS Deoghar. He has also received the Best Research Grant Award in the same year. He is holding ISM NIDA Fellowship in 2019 and DST Travel Grant 2017. Welcome, sir. So we are glad you having with us back. So I hand over the mic to you to make the panel discussion forward, sir.
Thank you, Dr. Vijit. I hope my voice is audible.
You're audible.
Okay. Right. So it takes me an immense pleasure actually to moderate this session. And I'm happy, actually, day before yesterday, I met Dr. Sonu and Dr. Amit at NIMHANS. And today we are here to, again, discuss about reflecting on our progress and path forwards
path forward in the area of tobacco control, specifically focusing on the tribal population. As a general rule, I would request all panelists to keep their answers brief because we have 45 minutes of time and we will have at least 2 rounds of discussions throughout this panel discussion. Without wasting much time, I would ask Atre Ganguly Madam. Madam, tobacco use disorders and addictive disorders come under mental health conditions in ICD. And tobacco-related work in India appears slightly separate from mental illness. Do you agree with it? And how do we integrate or strengthen tobacco and mental health from your experience?
Am I audible?
Okay, ma'am. Yes, ma'am.
Yes, okay.
Yes,
Am
ma'am.
I audible
Yes,
now? Okay. Okay.
Yes,
Good
ma'am.
morning. And at the outset, I would thank the organizers for giving me an opportunity to be here. The pace setting presentations were really putting in line with what we would be discussing. So as you rightly said, tobacco disorder and addictive substances, they appear to be different. But however, just to let you know, in the ICD-10 and also in ICD-11, tobacco disorder, now in ICD-11 termed as disorders due to nicotine use, are a part of mental health, under the mental health category, which does not make the two different. So this is number one. Number two is that we do have, because of certain policy decisions, we may be having different programs for tobacco control and mental health, but the faculty are essentially the psychiatrists and psychologists, people from the mental health fraternity, who actually leads the system. And if you see the approach, if you see from the public health approach, I would not go into the clinical specificities of the treatment. But if you go with the public health approach, that addressing both the conditions are in similar lines, which starts from prevention, promotion, and also rehabilitation and overarching policy framework. So if we see, a lot of things come from the preventive aspect. We do have COVID, which has brought about, COVID is a major factor very recently, which saw the surge of both mental health conditions, and I'm sure there have been a lot of increase in the tobacco consumption as well because of people's anxiety, stress, and solitary confinement. So the risk factors are the same. Number two, the approach are the same, wherein there has to be preventive measures with the, especially the youth who are coming up. And if we look at the tribal population, definitely they are a vulnerable population. It is ingrained, tobacco use is ingrained in their cultural norms, and not just in the tribal population. I would say in India, it is a cultural norm to use tobacco. So much of it is ingrained in the cultural ethos. So changing their mindset is definitely a main task. Similarly, mental health also, people don't consider it as a disease. It is usually a social condition. So that is another region. Thirdly, we do have to have behavioral interventions if we really need to reach out to it, and behavioral interventions both for psychotherapy and pharmacotherapy. Peer support is very important because both mental health and tobacco use require a lot of community support, which includes the patient himself, the family, and also the people who work around them. And of course, the policy around that, how to have the two interlinked is very important. And I feel that contrary to the usual presumption that mental health and tobacco are different streams, I would really beg to differ from this and would strongly advocate for a very integrated approach, because the comorbidities, it is mental health precipitates tobacco and other substance use, and tobacco itself has got some mental health comorbidities associated. So with these words, I would like to end my answer. Hope it is
Thank you, ma'am.
fulfilling your
Thank you. Thank you. I think, as you rightly highlighted, at a policy level, although the approach work seems to be separate, but at a public health approach for both tobacco and mental health is similar, and risk factors and behavioral interventions seem to be similar. And And it is also important to integrate the approach, as you finally pointed out that an integrated approach is something that is needed. And I have more questions to you, ma'am. But before that, I would ask Professor Sonu Goyal, sir, from your experience, can you synthesize and summarize the learnings in tobacco control, which is again more relevant to the tribal communities?
Thank you, Dr. Narasimha.
Yoga.
I'm really, am I audible?
Yes, sir. Yes, sir. You are audible, sir.
Right, right. So first of all, I think again, as Atriya has said, congratulations to Dr. Saurav Varshney for and their team for an excellent start of these a series of webinars. And I have seen their team in last almost 7 to 8 conferences where they have disseminated this tobacco control in various conferences. So I think a salute to Dr. Varshney and their team for doing such a wonderful work in the country. And as we have hosted a meeting for the consortium for AIIMS, in which Dr. Varshney was part of it, I believe that this AIIMS is doing wonderfully well as comparison to many other AIIMS which we have met during the meeting. So also, I think Upendra has made a wonderful start. Always a pleasure listening to Upendra. And Atriya, my colleague in PGI. So I think nice to see you. I think after NCTOH when we met in Delhi. So nice to see that I think you are integrating that mental health component. That is very important. And I think I would like to listen more from you that when it is coming under ICD, under mental health disorders, so so that means tobacco is a disease. So it's a definitely a disease. But I'm just wondering, like, if somebody has categorized a death due to tobacco use under some condition, like under some number. So is the number given to that disease and has it been reported somewhere? Because that will be a huge advocacy point if somebody categorizes tobacco as a disease and death due to tobacco. So I think I will like to start with uh, contextual to tobacco, because I have been working in tobacco control for quite some years now. And what we know in tribal community, as Dr. Janvi has also pointed out in the first presentation, that the tobacco use is very high. She has pointed out 50% or so, 50 to 60%. And one of the deaths, I think she also pointed out that 8 out of 10 boys or males are using tobacco in tribal community. Although in FGD, you will find the female component as well, which they might be hiding. But yes, I think, so this is what we know. So we don't have to do prevalence surveys. So that is for sure, because we know that tribal community, I think prevalence is high. They are using varied type of tobacco products. So what we need to do is, number one, is increasing their awareness. Because as a common man, in common man, we know that there is a good amount of awareness, but there, I think lack of awareness is there. Some product they might be terming as herbal. So that we need to see that which products they are actually advocating that they are good for health. There might be some tribal community which might be thinking that these products are good for health. And why we need to do that survey of awareness is then we can design those contextual strategies. So those awareness IEC strategy will not work, which might work in the general population. So I think that's the first line of thought which I'm thinking about, that we need to see the level of awareness. We need to do some focus group discussion more into it and to see what tobacco products they are actually thinking that they are good for health. Number two is we need to design tailored intervention. As I think Dr. Atriya has also pointed out in her earlier presentation, and also Dr. Upendra, that cessation support, I think cessation support is needed. They might be addicted to it. Some might want to leave tobacco products. So we need to see the study that like in which phase they are. Like, are they in pre-contemplation phase, contemplation phase? What is the level of I think in social behavioral theory, at what level these people are, right? So that we need to study. And if they are in the contemplation phase, then I think we need to start with those people. And if we start with few of those people, they can have a domino effect. Like they will replicate the same thing in the community. And again, this is second. The third is because I have worked in Northeast component, Northeast part for 1 year as a part of my UNICEF tenure. And I have seen that the best strategy which work in Northeast, especially the tribal community of Northeast, is using their own population, the tribal leaders, right? So we used to catch hold of those people, those in church, and those who are actually decision maker in their own community. People listen to them very clearly, right? In general population, it might not happen that we listen to our pujari or this thing, but in their setup, in tribal setup, people listen to them. So we need to catch hold of them. We need to do sensitization of those leaders specifically, and then we need to design the intervention which are actually led by them. So I think this is the third thing which I wanted, that when we are thinking about specific intervention, whether it is for school health, whether it is for cessation support and all those things. So I think that is one. The fourth component is your medical college. I think your medical college has been doing, your AIIMS has been doing wonderful role. I have opportunity to listen in various conferences. Again, I'm saying that. And like you are replicating the same thing, not again directly by you, but by other medical colleges. So I have listened that in the earlier presentation that you have involved almost 28 medical college nearby. So I think this is the, again, this is the thing which we need to do, that involving more medical colleges and designing I think, what do you say, multi-sectoral and multi-component strategies. So it's not only AIIMS driving, say, 1,000 people here, but if you train 28 AIIMS, those 1,000 become 28,000. So 28,000 people will be able to reach. So this is how we need to cater to the effect, I think. So I think at this point of time, I am just opening the discussion that these are few things which AIIMS can further do. I'm sure that you are doing some of these things already, but just to have my thoughts on that.
Thank you, sir. First of all, I would like to thank the appreciation for AIIMS Deoghar for doing good work in this area. And I would like to kind of highlight what you have told is one in terms of using FGDs to tailor the IEC activities, tailoring the interventions per se, involving their own population and scaling up, which AIIMS has been doing for last 2 years in terms of the capacity building and involving other medical colleges to replicate the model. I will come back to you. Now I would like to ask Dr. Amit Yadav. Again, same question that I would be posing to Dr. Amit Yadav. Sir, from your viewpoint, can you synthesize and summarize your learnings in tobacco control, particularly focused on tribal communities? Over to you, sir. Dr. Amit Yadav. Sir, is there?
We are trying to finding out maybe some technical issues.
No,
Okay.
sir, he just left out by mistake, some network issue. He will be joining back.
Sure. So then, to save some time, I would like to ask Dr. Deepak Mishra, sir. Sir, you are around?
Yeah, I'm here.
Yeah. Yes, sir. Yes, sir. Again, the same question to you, sir. Can you synthesize and summarize your learnings in tobacco control from a civil society point of view, which is most relevant for the tribal communities?
Well, it's my pleasure to be working with the tribal community in Jharkhand, because the seats is working in Bihar and Jharkhand state, and most of our focused district is tribal districts. Like we worked in Khunti, we worked in Chaivasa, we worked in Simdega, Lohodaga, and in Santhal also our team has been working in Godda and Dumka, even in the Deoghar as well. So the kind of awareness level among the tribal community which we could find out while working in the field, that need to be enhanced, because we work with them very closely. I mean, here people are mostly from the tobacco control community in this platform today. These tribal communities are very, I mean, the gul. One is the smokeless tobacco powder, which is being used as the tooth powder. This is called gul. It is very popular among the tribal community. So, and even the childrens are using that gul, that SLT. And we also came across, while working at the district level, we came across many of the people are coming to the collector's office with mouth cancer cases, oral cancer cases for the financial support. So, and the prime, you can say, the cause for those kind of oral cancers are SLT and primarily gul. Then next comes is gutka, pan masala. Although government of Jharkhand has shown very bold step during the time of the COVID and even thereafter, they have banned all kind of tobacco product during the COVID period. But thereafter they have taken. After that they have. There is some disturbance, I think. No. Am I audible?
Yes, sir. Yes, sir. Go ahead, sir.
Okay.
Yes, sir.
Please so thereafter, just after COVID, government has taken decision to ban pan masala, which is the main. I mean, there is no product as such called gutka available in the market since 2013. So the gutka are being sold in two different pouches. One major content is pan masala, and another one is chotu kind of tobacco product. So if you ban pan masala, we did the advocacy with the state government. And they were convinced if you ban the pan masala, automatically that chotu is vanished from the market. So so government has got it tested and found that those all 11 brand of pan masala were adulterated with magnesium carbonate. So and they have banned those brands, 11 brands from Jharkhand, and it was continued till for the next 3 years. But as on date, there are some technical problem. Court has the matter was taken to the court by the tobacco industry, and so it is under consideration now. It is not banned as of now. So my point is, these are the two products, gul and the gutka. Say pan masala or gutka is very popularly used by these tribal communities across the state, and we need to work with them. And then comes the awareness level is not so high. Even in the schools or the educational institutions nearby, it is being sold. Many of the times we provided, our team has provided the hand-holding support to the local administration for the enforcement drive. Because as per Code Pass Section 6B, no tobacco product can be sold within the 100 yard of any educational institution. So these are few learnings our team we have from the by working with the tribal community in the state.
Thank you, sir. Thanks for highlighting the local practices in terms of the use of particular tobacco like gul and gutka and pan masala.
One more thing just I would like to add, because one product also called buraku, it is also popular in few part of the tribal area, particularly in the Kolhan area in Jharkhand.
Thank you, sir. Thanks for that addition, and also the importance of awareness that is lacking, and in terms of challenges regarding the legal enforcement challenges that you have highlighted. If Amit sir is there, Amit sir has joined.
Yes, I am joined.
No. Okay, sir. So again, I think we missed out in terms of the question that I have asked you. Again, from your learning, sir, can you synthesize and summarize the learnings in tobacco control, which are specifically focused for tribal communities?
Yeah, thank Venkata for this question, and I think uh, kudos to AIIMS Deoghar for taking up and in terms of focusing on tribal health and especially looking at tobacco control from their perspective. I have been working in tobacco control from 2007, and as a public health lawyer and a lawyer from background, and especially person who has done his masters on human rights law. Now, I look at vulnerable populations and especially minors, children, and then you talk about tribal community, and within the tribal community, their children and the women in the tribal community. I think tobacco is a problem and a big problem for them, while they also struggle with their day-to-day life and day-to-day challenges, how they work, and the challenges from different perspectives. Some might even be engaged in, there are a lot of tribal communities which are tendu plucking, so in Madhya Pradesh and Chhattisgarh, Odisha, Maharashtra, and they are rolling BDs also. I think they have a lot of no, and then you top it up with the use burden. So a lot of them are using. It's the prevalence of tobacco use. If you look at the tribal areas of the country, or the districts with high tribal population, so you'll find that the tobacco use would be higher in them. Then, and even in the women and children, it is higher. And obviously, as we look at epidemiology and the progress of substance abuse, so we see that people who are marginalized, people who have less education, people who are living in rural areas, people who are and those are becoming the indicators or the deciders, or the determinants for the burden that they have on for these substance abuse, and tobacco is no exception. So I think so that's the challenge, and they have nowhere to go. No, they have nowhere to go until unless you have a focused intervention for them and make them understand. And as colleagues speaking before me, they have already suggested that it is their own language, which is peers' language, that is the best. And I think if you look at any vulnerable population, it is always the peers sharing and peers communication is the best way of engaging them. Whether it is children, you would find that peer education always leads to better behavior. Whether if you find in substance abuse, we have evidences that the peer communication, with whether you talk about Alcohol Anonymous, you would see that the peer communication helps them come out of that addiction. So I think that is very important aspect, and engaging them is important when you are making policies or when you are making interventions, when you are making any communication. Let us say we have tobacco control communications in the mainstream media or mainstream IC materials. If it is not tweaked to the settings of a tribal population, then it would have no meaning. No, you can run a full blown audiovisual media, and you might think that I've spent a lot of money, and this is going to help people come out of tobacco use or realize the burden. But your message might not even resonate a bit with the tribal community, until unless you have actually field tested the message, and if you have actually engaged them in the communication, then you may then you would have that change. So I think that is very important aspect of all of this. And in terms of communication and in terms of awareness, it is important that you engage them and you look at the problem from their perspective, or look at the situation from their perspective. They might not even thinking that tobacco use is a problem. So how to communicate that it is a problem, and you need to look at it, and you need to think about it, and you need to then come out of it. I think that communication needs to be from that perspective. Another thing is, when I think about tobacco control, so this is one, it is a behavioral issue, but it is also a legal issue for us. No, so we are talking about legislations which need to be implemented. Legislations, one, they need to be implemented, but second, when we make a law, it is with the anticipation and expectation that the benefits that the law is creating will reach to the last mile, right? So if we have a direct benefit transfer for buying cooking gas. So the idea is that anyone who is now buying cooking gas will get a direct benefit transfer of the money that is there to its account. That's the policy, and that's the law. No, if it is done by law, it should be there. No, let us say if we are getting a benefit in tax exemption, it means it should be available to anyone in the country, wherever he is, and in the manner the tax exemption is given, isn't it? So, in the same way, if there is a law which suggests that tobacco use or tobacco should not be available or should not be sold to a person below the age of 18 years, this protection of law should be available to all the children in the country. And if COTPA says you should not sell them to minors, and if the Juvenile Justice Act says that you cannot sell, you cannot give or causes to give tobacco to a minor, then the benefit of this law, which the lawmakers and the parliament know in its all wisdom created for the people, it should be given to the people. So I think that somewhere in terms, again, this is also a matter of communication. This is also a matter of implementation. We need to work with the community, work with the tribal people, tribal community, and the leaders and peer groups, so that self-help groups, so that the benefit of the legislation and its actual enforcement and translation in their practice is given to them. So I think that is where no, I would suggest that we that should happen. But I think these are the communities which are well knit, and if something, if you are able to click with them or resonate with them, it is going to be accepted much better way than any other heterogeneous society. No, you may find it very difficult to implement something in Bangalore from one ward to another ward. But if you are able to convince someone in Devghar, or someone in that tribal community in Jharkhand, then you would see that all of them has actually adopted the behavior, and it is much easier in terms of implementation because the homogeneity of the population is there. So I think that is what I would look at, and I think thank you to
Thank you,
the
sir.
thank you to the whole
Yeah,
team for taking this
yeah,
up, and also in terms of engaging larger tobacco control community to discussing tribal health and tribal population and the burdens that they are having because of tobacco use. So looking forward to
yeah,
further discussion.
yeah.
So
So
may I?
thanks, sir. Thanks for ending in a positive note. In terms of if we are able to overcome that one step of the barrier, and it is easy to actually kind of work with the community and bring in change in a easier manner. So this is a positive thing, because we always discuss about the challenges, but once we overcome the first step of the challenge, then it becomes easy. Uh, I would keep the questions towards the end. I think Harshita wanted to ask some question, but I would like to keep it at the end. Is that okay, Harshita? Okay. So I would now request Dr. Sudeep, sir. Now this is the fifth of the virtual conferences that we have conducted. If there are three takeaways, I would be more specific that I wanted you to tell three takeaways in this all the five workshops. What and how do you look forward in terms of implementing some of these key takeaways? Over to you, Dr. Sudeep.
Thank you, respected ED sir, the PI of this project, my team members, my HOD, Professor Janavi, and all the colleagues are working in India and across the world regarding tobacco to the last mile for improving the lives. So already before putting a message, Dr. Narasimha, that I have already made my points clear in three points I will discuss. But I cannot. I want to express two more things, that it is a great day for me when a teacher and a student is sitting in the same panel. So it is a great day for me. And thirdly, these opinions are all are personal, and there is no conflict of interest. Now I am studying my questions, answers. So what I already described by our Professor HOD ma'am, Professor Janavi, that already I have divided into three categories. One is individual level or micro level, in the community or meso level, at the national level, policy level, or macro level. So what already described, I'm adding the points regarding individual level. It is a habit basically, tobacco. So it is a cultural habit, maybe it is a behavioral habit. So behavioral medicine is a very much important to role to play these things, to make them awareness generation and these things. This is the first thing, because it is a, as Professor Goel has said, that it is a different ball game between tribal community and civil community. So you have to approach should be different, and tailored intervention, as also three man also tell, that tailored intervention is important. So individual level, just an example I am giving, some people tell that in the tribal community without smoking biri they cannot go to toilet in the morning. So this is a daily habit. In menstrual problem or any pain problem, they used to give nicotine water to relieve the pain. So these are the, they use as a medicine, they use as their culture and habit individual level. So we need to make them aware. Second point is community and meso level factors. Community level means wherever we go. As example, I am quoting example of Punjab. In a Punjab wedding or any reception, it is incomplete without alcohol. So similar things in Jharkhand also, in tribal community, without offering a nicotine products or tobacco products, it is a incomplete for them. So we need to educate the community also. And macro level factor or national level factor program is going on, implementation is going on, and different NGOs like Professor Misra, Deepak Misra sir is working very hard, and we have already working on that. So we need to add on and work in a synchronous manner, because some work is already done in every state. I firmly believe not only India and across the world, already work is going on for tobacco. We need to complement each other to make things better. Thank you very much.
Thank you, Dr. Sudeep, for being crisp and highlighting three important levels at an individual, meso level, and macro level. Again, there is a suggestion from Dr. Upender Bojani that it is very important to incorporate speakers from Adivasi communities. That would be crucial to avoid this we-they divide. Thank you, sir. I think we would take that important suggestion, and we will move on to the next round of discussions. Again, the question to you, Madam Atre Ganguly, that you have highlighted the importance of integrated approach. Pragmatically, at a policy level, how do you look at improving the access to mental health services and tobacco cessation for tribal communities? So, over to you, ma'am.
Okay, thank you once again. Sir, your question has a few compartments. One is healthcare for tribals, and secondly, it is how to reach about the mental health and tobacco together. So, answering for the first, why healthcare for tribals, we know that SDGs, there is a clause saying leaving no one behind. So, unless we address the needs of this population subgroup, we will not be able to attain SDGs. We do see that there was a report in 2013 which was jointly published by Ministry of Health and Family Welfare and Ministry of Tribal Affairs, wherein it brought about some very hard-hitting facts that there is a gap in terms of human resource, gap in terms of their functioning. Then the culturally acceptance of the modern medicine was also low. Then also the management and supplies, because many a times these are in very isolated areas, so it is not always what possible to have the same inflow of drugs and essentials and also human resource as it may be in other parts of the country. However, our government is very cognizant of this fact, and there are certain clause which brings about, like tribal population is considered as a Indian, I mean, special population, wherein the norms for public health infrastructure are quite enhanced. Like the sub centers are there for the 30,000 population, PHCs for 20,000, CHCs for 80,000, and also there is ashas and Ayushman Arogya Mandirs, one in every 30,000, 300, the 3,000, unlike the 5,000 norm otherwise. So these are very progressive steps. These must be made use of, and this is very important, number one. And this the tribal community themselves, and I would really compliment Dr. Upendra for his observations that nothing for the people without the people. So we really need them on board. They themselves have to understand that there are opportunities which are there for them. They need to harness them, they need to utilize them optimally to get the maximum benefit for their own people. Secondly, apart from the health, we also see that there are many schemes by the government to enhance health literacy, school education, to address special groups like the pregnant women, elderly, those who are providing them adequate employments to keep them away from these addictions. These schemes are also there under the social justice and also the Ministry for Tribal Affairs. So they also to be harnessed. So again, people from the community has to be a part of the planning process and implementation process. Secondly, for mental health, these days it has come up in a very big way. It is one of the flagship programs of Government of India. We've seen a very important scheme called the Telemanas, that is the tele mental health network across states. And Jharkhand is also there. Ranchi is the one of the mentoring centers, and I would really suggest, since AIIMS Deoghar is doing such excellent work, and you have the multidisciplinary collaboratory environment, that is very important, that you have the collaboratory environment. Why don't you start a small project in your community health community medicine field area, wherein you are able to integrate the different programs, and with the special focus on health for the community, at the community, by the community. So that would be really important, because once we have a functioning model, then it will be easy to replicate or maybe adapt it to the different situation settings of the country. But the first step is very important. So I think this is a very important step, which I'm sure our organizers would really love to do, and we are there to support you. Thank you.
Thank you, ma'am. Thanks for a very important point, leaving no one behind, and also highlighting the importance of harnessing the schemes that has been driven by government, particularly focusing on Telemanas and NTQL, and also the suggestion for AIIMS Deoghar to take forward this initiative, focusing on the tribal communities that they have been serving because of the multidisciplinary approach. Thank you, ma'am. Dr. Sonu Goyal, sir, you have been part of scientific support groups across India and integrating all the AIIMS and other institutions. How do you think the collaborations and training help achieve a vision focused on tribal communities? Sir, you have to unmute. Yeah.
So thank you again for this very important question. As I told earlier as well, that we need to collaborate and we need to work strategically. That is again very important. For meaning of strategic means, like we need to map out the tribal areas. Of course, you might have done in the country. If I think AIIMS Deoghar can definitely take a lead, having a center over there. So I think mapping of various tribal areas in the country, that is first. Number two is mapping the medical colleges and the AIIMS nearby, those areas. So I think that's the second step which needs to be done. And then having a meeting, having a closed group meeting with them. And there we need to see that what we need to make a joint plan in terms of some implementation activities, like Deepak ji have said, like what we need to do specifically, implementation activity. Then joint plan for doing contextual research, which is meaningful, may not be limited to say Jharkhand, but it can be like Jammu and Kashmir. There are some specific tribal community in J&K. There are other tribal community in Assam. So I think we need to make that we need to deliberate, dwell upon what are the common things which we can do research on. Some are contextual, some are common. So that we need to deliberate upon. And so this is number one. I think mapping out of all tribal areas in the country, mapping out of AIIMS, and you can make a consortium of all the colleges or AIIMS which are nearby. So that's the one thing, and we have got a good experience, and definitely we'll be glad to assist you in that endeavor as well. The number two is like discussion in conferences, meetings, not only in public health meetings, but also I think I've seen you in National Academy of Medical Science meeting. I have seen you in ENT meeting. So whatever diverse group of meetings we have, again, we need to make a plan that these are the conferences, these are the people whom we can approach in different fraternity, and these are their national meetings. So if we can disseminate more in the national meeting, I think they will be helping us or supporting us in this way. So this is another way of collaborating with people. Third important thing, which we have got some experience as well, is joint research. Like recently, we had a program that is mentorship program. So in that mentorship, research mentorship program, we could collaborate with around 40 different medical colleges from different parts of the country. And 40 teams are working on specific areas. Like we chose in last year, hypertension and tobacco use. One is tobacco use and one is hypertension. Either of them can be a dependent variable. So we chose that, and then we galvanized that research, and happy to inform that like 10 have been published out of 39, and around 20 more are still in offings. There are papers who are roaming around in different journals, and 9 they are still writing. So this is how we can galvanize specific contextual research for tribal health. And Ministry of
तुम्ही जे
Tribal
इकडे
Health
आहे
will be
ना
happy.
तेव्हा तुम्ही ते आणि बुक रजिस्टरवर पण सह्या घेऊन घ्या.
So Ministry of Tribal Health will be happy to take this research forward. If you give them this idea that we want to do a pan-country tribal research and many more research. I know Dr. Salim from J&K, so they are also doing some tribal related things. So they will be happy to take part in the research, and maybe WHO, I think Dr. Atreya is there. So if we are talking about specific tribal related community research, so they will be happy, and that's really important. The fourth thing is involvement. As I already told you in earlier, involvement of not only in academia, but also other than academia, those who are part, like NGOs. We need to find, again, map out, like we have mapped out the AIIMS and medical college. We have to map out those NGOs, those non-governmental organizations, those civil society who are actually working for tribal health, because they will give you insights. They will give you a ground level insights, which we academia can't get unless we do that in-depth interviews and studies, which takes a lot of time. So I think involving the civil society and NGOs is really important. And again, mapping of this is needed. And fifth one is designing a tailored training program. So not only for academia, but also for different type of stakeholders. So we can think of that these are the stakeholders which are needing those programs. And again, those programs will be, if you are designing a IC program for, say, a training program for a ground level people. So that's a very simple language, as Sudeep has told, that very simple language, very clear language. And when we are designing a technical program for medical professionals, doctors and all, so that can be. So I think these training programs can be there, right? And Resource Center for Tobacco Control already doing some programs, so we'll be happy to support in that program as well. So these are the things which I can see in terms of collaboration and training, which will be useful, I think, in the future run. So I think this can be a strategic plan for the institute. Thank you.
Thank you, sir. Thanks for putting a strategy to collaborations in terms of mapping, integrating joint research, and involving people and providing tailored regimens. So that's an excellent strategy that we can start implementing in terms of collaborations. I would like to ask Dr. Amit, sir, in terms of international collaborations, how do you look at working with international agencies in terms of, again, collaborations focused on tribal communities? Over to you, sir.
Yeah, thanks, Venkata. I think in international collaborations with respect to public health, and I think a lot of international community do work on that, and especially let us say if you talk about tobacco control also, I work with the union and then now at the Vital Strategies. There are other colleagues in the World Health Organization and other UN agencies who are working in tribal communities and for public health, and colleagues in other organization campaign for tobacco free kids. So all of them are working to advance tobacco control. And if you look at tobacco control, we consider that tobacco control is one of the risk factors, or one of the factors responsible and that undermines sustainable development. And if anyone is working to eliminate the burdens of tobacco, it's actually supporting sustainable development, and any kind of that development, the benefits will still go to all communities, including tribal communities. However, in specifically dealing with, I think know we are having two grants in Jharkhand. We are also working in other states where tribal communities are there. Colleagues in Maharashtra are working with tribal communities, colleagues in Chhattisgarh and in Madhya Pradesh are also working. We are working in Northeast, in Tripura and in Assam. So we are also and working very closely with the National Tobacco Control Program and the government's priority of reducing the burden of tobacco use across the country. So that is being there. Again, especially for BD rollers and tendu pluckers. So we are working with them as well. So I think this is also another important aspect, important contribution of international agencies and international collaborations, which is also helping this national collaboration and even local collaborations. Recently, again, I was in Assam and we were talking about collaborative effort in advancing tobacco control. We talk about multi-departmental, multi-sectoral, and I think in the social context also inclusive and collaborative work where all partners have their say. And completely agree with what Dr. Upendra said about including more tribal voices, also including more people from the community to talk about these issues when we are working in this field. Then I think I'm hoping that at AIIMS Deoghar itself, when in the due course you would have PhD scholars, you would have MBBS and MDs who are going to take up these issues, and they will be from the community itself, and they will be representing those voices. That would be really nice. I think this sentiment that Upendra has expressed, I feel that both for any other marginalized communities and within tobacco control, I also feel that in terms of gender equity as well. We have very little representation during such discussions and during such policy discourses and even implementation, and we miss that most of them are led by men. And we have, while we were with all the men sitting and they will be talking about burden of tobacco use among female and girl child and all that, and you don't have you know a, a woman or a leader, female leader to talk about that and to take the things forward. So I think that capacity, and that is where Dr. Sonu Goel, while working with the consortium with the AIIMS and wherever we are working with different collaborations, we need to look for these inclusivity, that representation. We are working in a democracy and we are living in a democracy, and I think certain kind of affirmative actions are always expected from at every level. We and Our constitution calls for no discrimination and I think inclusivity for all, irrespective of caste, creed, sex, race, and all of that. So I think from that perspective, both at the international level or at the national level, I think this collaborative effort is important, but with an inclusive and participation of the community itself, and with a louder voice from the affected community. If you are talking about gender, and if you don't have maximum number of females talking about it, then it's of no use, no, because you may be talking about it, but you are actually not the one who is facing it. You are not the actually one who is relating to it. So you may talk about that, and I think it is important that we at our level, whether it is AIIMS, whether it is other legal institutions, lawyers, whether it is public health institutions, or whether these are medical institutions, so they need to do that. And I think government policies also talk about that, and I hope that in the coming time, as we move forward, these gaps will be closer, and that these gaps will be filled more. So yeah.
Yeah. So thank you, sir. Thanks for highlighting the importance of inclusivity, apart from also highlighting the importance of involving or the vision for the local communities. Specifically, the point that you have highlighted about the medical students who have been from the tribal communities working in or studying at AIIMS Deoghar, and they taking up future work related to the tobacco control, specifically focusing on tribal communities. Sir, as we are overshooting on time, I would request Dr. Deepak Mishra to make a simple comment related to the importance of civil societies in achieving the vision, which is focused towards the tribal communities. Over to you, sir.
Yeah, because yes, really we have overshooted the time. I do agree with Dr. Sonu Goel, sir, who has highlighted the importance of the collaboration. And as far as civil society is concerned, the role of civil society is always significant to reach out the marginalized community, particularly tribal community. And tobacco control is not the baby of one of the single group, like neither government can do alone, nor the academia can do, nor the law enforcement. So it is a collaborative effort, and the role of different department, the role of different group is highlighted and defined. So as far as civil society is concerned, even taking the benefit of the NTCP in the tribal area, you need to engage the civil society group, because we are the civil society group is the one who can directly connected with the marginalized community, tribal community, and based on the input of the civil society group, academia can do some research, and based on that research, some good policy can emerge, and made on the recommendation by the academia, government can jot down some policy. So there are all are interlinked. So you cannot ignore. You have to have the civil society group for any of the program, particularly for the marginalized, and the local level leaders. The peer group is also very important to include, because and the civil society is one group who can easily having access to those local leaders and local peer group of the tribal group. So this is what can the role of civil society be there.
Yeah. So beautifully put across in terms of the interlink between civil society, academia, and connecting to the government for policy implementation. Thank you, sir, for such a important link that you have explained beautifully. Final comment, a one-line vision statement from Dr. Sudeep Bhattacharya in terms of learnings and implementing these learnings that we had all through the workshops and the research that you have been doing. Again, a single line comment, please. Thank you.
Single line, I need to categorize two this time.
Okay, 2 lines.
Yeah, 2 lines, right? 2 paragraphs basically. So 2 points mainly. We are actually working simultaneously, because whenever we make a project, we make a Gantt chart and we start simultaneous working. So implementation is going on side by side, other research and these activities. And I am dividing in 2 major aspects. One, what AIIMS team is doing inside the AIIMS and outside the AIIMS. Number 1, inside the AIIMS team, we are doing regularly continuous quality improvement process like Kaizen, Kanban, And we have done original research by Dr. Vijit Viswas and Dr. Venkat Lakshmi Narasimha has done a systemic review and meta-analysis, which is under review, I think. And we are planning for operational research, action research, and implementation research for future. And outside the team, we are doing, we are regularly conducting meeting with the stakeholders, just like administration, Panda Samiti, giving regular updates with municipal corporation, policymakers, religious leaders, not only from civil society, but also from tribal communities. And we have already done, Professor Jannavi has done 3 FGD already. So I think apart from that FGD, more FGD, we can go for a positive deviance approach, and we can print IC material in their Santhali language or local language and distribute them for IC, improvement their knowledge. And lastly, the reducing or amalgamation of the ethic and emic approach or gaps is there. Ethic and emic gaps is there regarding tribal community and non-tribal community. We are trying to reduce these gaps. And with the last line, what Dr. Narasimha was trying to tell me that we are trying to connect the dots across the world for the harmful effects of tobacco. So we think hopefully together we can. Thank you very much.
Thanks, Dr. Sudeep. And I would first of all apologize for overshooting on time, but this is one interesting discussion that we had, having inputs from experts across the country. And again, if I have to give 5 points that highlights this discussion is leaving no one behind, mapping of the resources, the FGDs and the vulnerable communities that we have talked about, and the interlink and the vision that has been presented by AIIMS Deoghar. I would like to thank all the speakers, panelists for being present here and sharing your valuable inputs. I would also thank the participants for actively listening. If there are one question from the participants that we can take, we would like to take. Anyone would like to ask a single question for any of the panelists, please. I think in between Harshita had some question. Can we see any question from the chat box? I think there are a lot of suggestions from Dr. Upendra Bujani. I think these are important. I am sure our team will actually compile all these suggestions and will share summary with all the participants that we will do. If there are any questions, Dr. Jahnavi, you have some question? No, okay. Okay, so if there are no questions, I would like to hand over to Dr. Bijit for final comments. Thank you all.
Thank you, sir. So we are at the very verge end of our virtual workshop. So now I would request all the participants to kindly switch on their mic so that we can have a group photograph.
Video, not mic.
Sorry, video. Their cameras, so that we can take a group photographs.
My camera is still not working, Dr. Vijit.
Sorry to hear that, sir, but thank you, sir.
We will put your photo, sir.
Yes, sir.
We will take your photo and crop it.
Please, all of you smile for the photo.
Those who have not switched on their video, kindly switch on their video so that we can take a beautiful group photograph. Thank you so much. Just before finishing, so this is the QR code. So at the initiation of initially we have asked you to fill a registration questionnaire. So this is the post-test questionnaire. We would request you to kindly scan the QR code and answer to the questionnaire. So on filling of this post-test questionnaire, you will be awarded with an online certificate from AIIMS Deoghar and Vital Strategies. So we would also like to announce that on 10th May, we are organizing a national workshop on tobacco control among tribal and indigenous communities of India at AIIMS Deoghar. That is in offline mode, not in the virtual mode. We are supposed to do 5 virtual workshops. So this is the last workshop we are conducting, and we are very privileged to have all the participants and panelists that we are having with us. So we would soon we will release the brochure for our national workshop, we will request all the participants to kindly register and attend the workshop physically if possible, and have a holistic opportunity to view the famous Bednath Dham temple also. Okay, so I think you have scanned the QR code. So now I would like to invite Dr. Vinayaka Murthy sir to deliver the vote of thanks.
On behalf of Vital Strategic Tobacco Control Team of AIIMS Deoghar, I feel privileged to present vote of thanks for today's fifth and last VC that helped us to reflect on the progress and consolidated our learning. I express my sincere gratitude to our respected Executive Director, Sir Professor Dr. Saurav Vashne, who constantly motivates and encourages the team to perform our best. I thank Professor Dr. G. Janvi Madam, the Head of Department of Community and Family Medicine and organizing chairperson of today's VC, who supports us in every step of the project. I wholeheartedly thank the external speaker, Dr. Upendra Pochani, and all panel members of today's panel discussion, starting from Professor Dr. Sonu Goyal, Dr. Atreyi Ganguly, Dr. Amit Yadav, Mr. Deepak Mishra, and Dr. Sudhir Bhattacharya, and the external moderator of today's panel discussion, Dr. Venkata Lakshmi Narasimha, for sparing their valuable time and sharing their experience and expertise with us. I thank Dr. Santanu Nath for being organizing secretary, and my thanks to Dr. Vijay and Dr. Ashar and the project staff, Dr. Benazir, Dr. Ujjwal, and Mrs. Nivedita for coordinating today's event and also providing logistic support. Finally, I thank all participants who actively participated in today's event and making this event a grand success. Thank you.
Thank you, sir, for the vote of thanks. So with this, we are concluding our virtual workshop on fifth virtual workshop on tobacco control among tribal and indigenous communities of India. So it's a weekend and it's a long weekend. So all of you have a happy Holi to all of you and happy Ramadan also. So hope to see you in the national workshop. Thank you.
Thank you, Dr. Vijay.